Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization with the strategic mission and vision of furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I am a dental surgeon and also the course director for an online YouTube series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. This is Lecture 2, Preliminary Evaluation and Treatment Planning. So what is preliminary evaluation and treatment planning all about? It's all about data collection. I once had a mentor of mine once tell me, the more data you collect, the better. You can never go wrong with collecting more data. So why? The main purposes of collecting data are to avoid mistakes or complications, meet the needs of the patient, and communicate for the future. In implantology, any surprises are never a good thing. Those who teach, we describe ourselves as mastering the art with a great deal of practice. So what makes us masters? We're masters due to failures, and we learn from our failures. If you fail to plan, you plan to fail. There's an old expression which says, don't shoot yourself in the foot. Well, the only thing that's worse than shooting yourself in the foot is reloading the gun and shooting yourself in the foot a second time. So everything starts off with a medical history. This picture basically is a photograph of a standard suggested medical history that most dental offices take for their existing patient base. What are the key things to sort of pick out of these medical histories? Which aspects of this medical history are issues that may be very relevant to the practice of implant dentistry? So in terms of this medical history, we look for things like immunodeficiency, uncontrolled diabetes, smoking, alcoholism, bisphosphonate use, both oral and intravenous, patient dexterity, the patient's ability to maintain their oral hygiene, vascular disease, anticoagulants, head and neck radiation. We then move on to a more thorough dental history for the patient. Factors regarding the loss of the tooth that's being replaced. So what we need to know here is when did this tooth loss occur? How did it occur? And why did it occur? And these are important to understand because we need to understand why these teeth were gone in the first place, as these may be factors that we need to address in our treatment plan in terms of being able to not just restore the teeth for the patient, but also prevent further loss. Factors that may also affect hard and soft tissues, traumatic injuries, failed endodontic procedures, and periodontal disease. And finally, the presence of parafunctional habits and anxiety. Parafunctional habits are described as the grim reaper in dentistry. We will discuss this more in the dental complications lecture. And anxieties can never be a good thing for a patient. So we then move on to the chief complaint. The chief complaint, as we know from Dental School 101, is what the patient says in their own words. But it also comes to communicate the expectations from the patient in terms of function, aesthetics, home care, and long-term costs. Sometimes patients will come in and say, I want dental implants. I heard that they last forever and that I don't need to brush my teeth. Well, we all know that that sounds like an ideal want from the patient's perspective. However, from a reality perspective, this is not something which would be very realistic. Then we then move on to the history of the chief complaint. What has the patient used in the past to address their issues? Issues that have occurred with the patient's use of these past interventions. Treatments that were attempted, and finally, a periodontal history on the patient in terms of understanding that what soft tissues and hard tissues are remaining around their existing dentition. So major indications for treatment. I was once told by a mentor of mine that the number one reason for patients seeking dental implant solutions is factors precluding the wear of a removable prosthesis, and that the number 2 reason why patients will come to my office seeking a dental implant solution is factors precluding the wear of a removable prosthesis. And as you guessed it, the number 3 reason why a patient will come to my office to seek a dental implant solution is factors precluding the wear of a removable prosthesis. So what are these factors? These factors would be things like poor hard and soft tissue anatomy for denture support, poor oral muscular coordination, poor mucosal tissue tolerance, a hyperactive gag reflex, a psychological inability to wear dentures, and finally single tooth loss. So we then move on to our examination. And we basically want to conduct a thorough intraoral and extraoral exam. We want to look out for things like the presence of oral pathologies, and as we mentioned 3 times now, a periodontal exam is imperative from the long-term prognosis of any sort of implant solution. And finally, the ability to open in terms of, from a surgical perspective, being able to access the implant sites and also be able to reasonably maneuver some of the small tools like the screwdrivers and impression copings that we routinely use inside the patient's mouth. We then move on to treatment records, more data to be collected. So in terms of treatment records, what do we recommend? So study models and other aids, photographic records, diagnostic setups, radiographic records, and surgical guides. Now, you don't necessarily need all of these things for like routine simple cases. However, when one is first starting up, nothing beats having every tidbit of data that one can collect and be able to reflect upon either prior to, during, or after treatment in order to learn from your cases. So in terms of study models, we have a photograph of some standard orthodontic study models that have been taken, and in this patient you can see there is a unerupted upper left cuspid. This is an occlusal view of the same patient. So these things can definitely give you an idea of where things lie in a 3-dimensional state. They also permit the opportunity to do things like create wax-ups and surgical guides, and even do things like model surgery, as you will see later in this presentation. Photographic records are also an excellent way to get a better idea of where things lie in a 3-dimensional perspective, and these can be correlated to the study models as well. As they always say, a picture is worth 1,000 words. If one has not actually been able to acquire any sort of means by which to take intraoral photographs, one of the systems that we use in our office is the Nikon setup from Lester Dine. This can be purchased from lesterdine.com, or also, if you're in Canada, from henrys.com. The previous camera that was like the gold standard, which was just awesome, was the Yashica Dental i3. Unfortunately, this was a film-based camera. I held on to mine in a very stubborn manner for years, hoping that one day they would come up with some sort of a digital conversion kit or a digital version of this camera. When you compare this camera to the camera set up above, which is what I currently have, a Nikon D3100 with the Lester Dine ring flash and point flash, one can appreciate that it was much smaller and much more convenient to use in the operatory. There's also 2 really good courses that I would highly recommend anyone take. One's given by a dental photography master, Ms. Rita Bauer, who was one of my instructors in dental school, and there's also Dr. Ron Goodlin. I'm sure across North America there's a number of excellent instructors. However, if you're seeking a course, I would highly recommend both of these individuals. Diagnostic setups. So this is a photograph of a diagnostic setup that can be basically set up by your lab very easily onto a patient's study model, or sorry, not onto the study model, but onto a copy of the study model. And what's cool about diagnostic setups is that one can easily take these items and, as you can see, here's a shot of this diagnostic setup from the occlusal. Take these setups and replicate these in stone. And by replicating it in stone, what you can do is have your assistant or one of your staff members very easily make a clear stent from these setups. And what's neat about these clear stents is that you can actually take these clear stents and fit them right over the patient's existing teeth with some sort of a temporary material. I like using a bisacryl material like Integrity and or ProTemp or any one of those sorts of ones which work well for you. Fill it up and more or less place it right over the patient's teeth, allow these to cure, and when you remove them, it gives the patient a wonderful idea of how things are going to look. And more or less, it communicates to the patient what it is that we're planning to do and what it is that we can do, and sort of gives them an idea of where things are at. Now, they can communicate to you from this point whether this is something which they're seeking or any modifications that can be made. And what's neat about this is that it's a fairly easy, simple, cost-effective, non-invasive way to basically take a look at the end result, and any modifications that need to be made can be made at this stage, at this level. And then it simply just becomes a matter of taking an impression of this and copying your homework with respect to treatment planning, any sort of implants or crowns or any other prosthetics that will be going in, and being able to provide the patient with this outcome. This is a photograph of the bisacryl material in, and the next photograph, it's not the same patient, it's a different patient, but just shows a picture of the bisacryl material tried in as a temporary and with the margins trimmed and cleaned up. And as I'd mentioned, it's always better to sort of try to get these modifications made and replicate this using an impression and creating a model, and basically then just having to copy your homework, as opposed to going through the time, effort, energy, and expense of getting some sort of a laboratory prosthesis like this photograph, and then having the patient say, "Oh, I wanted this, or I wanted teeth that were this shape, or I wanted," and as I'd mentioned at the beginning of this lecture, surprises in implant dentistry are never a good thing. Diagnostic imaging. So, what's the value of diagnostic imaging? You absolutely require some form of imaging, unless, of course, you are Superman and you have X-ray vision. The limitations of diagnostic imaging basically are listed as three things: as calibration, two-dimensional versus three-dimensional views, and then also the everyone's favorite incidental findings, or we like to call them incidentalomas, incidental findings, and what the significance or clinical significance of these factors are. Intraoral Peri-Apicals, film or digital. These are very, very accurate. Do not fool yourself. Do not let any company ever tell you that peri-apicals have gone passé. Peri-apical radiographs are still my routine go-to radiograph when I'm seeking a very accurate view of the area in which I'm working, and also in terms of being able to determine where vital structures are. If something's close on a Panorex, I will routinely refer to a peri-apical, even from the cone beam CT, to a peri-apical in order to determine what the actual anatomy is. With peri-apical radiographs and Panorex film-based radiographs, you can use these things called overlays, and we'll show you that in a second. And in terms of digital imaging, there is calibration for imaging software which is available. In terms of calibration, there's two ways to do it. Some of the programs basically are already calibrated fairly well for you. However, if you doubt the accuracy of your calibration software, there are 5mm round basically ball bearings that you can purchase from any implant company. Salvin makes them. Some of the other implant companies that I've dealt with in the past will provide these for you as well. And you can basically put these in the patient's mouth using some sort of bite registration material or putty or something like that. And basically when you take your radiograph and you know that these ball bearings in the position in which they're in is about 5mm. And so you can use your digital imaging software to measure this actual ball bearing, and depending upon what the length comes out to, you can use this factor to figure out what the magnification factor for your particular imaging software is. Most Panorexes, they're generally between 25 to 30% magnification factor. I always err on the side of caution and go with 30%. So going to the Panorex, which is the next radiographic method we're going to discuss, it provides you with a larger view. And as I previously mentioned, using ball bearings, magnification factor is something which you need to consider, as it's not going to be as accurate as a periapical. Vital anatomy is easily seen, and it's also easier for patients who have large tori, narrow palates, or other factors which preclude the use of intraoral radiographs. Implant radiographic guides. So this is sort of that overlay that I was discussing earlier. This is an overlay from Glidewell Direct, and you can see that these overlays on the left, it says actual size, and there's a 10% magnification factor, and then they have a 25% magnification factor, which you can use for the majority of Panorexes. What's important to note, if one looks at the bottom left of this radiographic guide, you will note that there's a little small triangle on that domed apex of that implant. And basically what this is telling you is that the apex, the domed apex of the implant and the cutting edge of the actual drill, there's about a 1.5 millimeter gap there. So basically the drill cuts about 1.5 millimeters beyond where the implant is going to sit. And this is important to consider when one is working close to vital anatomy. We will tell you later in this presentation that 2 millimeters is generally the sort of the safeguard you should give yourself in terms of where to stay away from vital anatomy. So if you take the 2 millimeter, if you're planning to put a 10 millimeter implant in and you have an extra 1.5 millimeter cutting tip, that takes you to 11.5 millimeters, and then you want a 2 millimeter safety factor. So you better hope that whatever anatomy you're working away from is at least 13.5 millimeters away. Either that, or you need to basically consider using a smaller implant, or thinking of some sort of technique by which to mitigate injury to that piece of vital anatomy, such as a nerve lateralization technique or other modalities, which I wouldn't recommend you do as a beginner. This next picture here basically shows that radiographic overlay, the radiographic implant guide in place. And so you more or less could just take these over the film-based x-rays and get an idea sort of what width, what length of an implant would be appropriate to use in that case. A lateral ceph is also a useful tool, especially for patients who you're not quite sure what their bone loss looks like. So you can see in this patient here, if you were to take a Panorex on this patient, it would show that this patient basically has fairly advanced residual ridge resorption, and you can see that there in the anterior mandible, there's a nice little platform there which could be used for dental implants. However, you want to make sure that if you are planning to place implants in a patient like this, that you don't perforate out the lingual plate. In terms of diagnostic imaging, what are we looking for? We're looking for bone quality. We're also looking for bone quantity. I think I said that backwards. Associated structures such as the inferior alveolar nerve, the mental nerve, the maxillary antrum, the nasal floor, the incisive canal. You want to look for pathology, things like retained dental roots, peri-apical pathology, cysts, and other pathology. So a case against routine cone beam CT or CT scans. So some practitioners will say that they scan every patient. Some practitioners will say that they don't scan any patient. And some practitioners will say that it depends. I'm one of those practitioners that would say it depends. And the main reason I would say it depends is because right from Dental School 101, we were always taught the HARP principles, and one of the HARP principles is ALARA, as low as reasonably achievable. We all know that a cone beam CT or a CT scan is way more radiation exposure for the patient than just a standard peri-apical film or even a Panorex. There's also the expense that sort of goes along with this modality. As I'd mentioned, it's 4 times more radiation than a Panorex, It's a time-consuming process as well if it's not on site, and even so, if it is, many times you can outsource the interpretation of these, and that could take time from when you actually take the cone beam CT to when you can actually interpret the results and share these with the patient and come up with some sort of a treatment plan. Digital panoramic units also these days have tomographic capabilities and built-in measurement systems, which makes them way cool. And usually the cone beam CT or CT doesn't add any additional data over a standard database. In terms of image distortion, this is basically just a picture or showing a diagram of the various image distortions that take place and how we get the numbers of 25 to 30% as I previously described. The anatomical limitations that come from this, these are basically the areas or the distances that you should stay away from certain vital anatomical structures. As I'd mentioned, the 2 millimeters from the inferior alveolar canal is probably the most relevant for the practice of implant dentistry. So this is a picture of a cone beam CT. As I said, I don't routinely recommend you add in cone beam CT. However, what's cool about cone beam CT is you can do cool things like this, which is like virtual implant placement. You can basically figure out exactly where the implant's going to go in a three-dimensional space. And what's also neat about this is that these cone beam CTs can be used with software programs to come up with these surgical stents, which can more or less guide the surgeon in terms of how to place the implant into the appropriate three-dimensional space. One of the limitations of surgical guides is, as you can see here, by covering up so much of the surgical area, it sort of limits the amount of irrigation that's going to go into the area. And as we know, or we will discuss for later in this lecture series, the temperature thresholds, if they're exceeded or above, say, 47 degrees Celsius, we know that this is not good for bone health. It actually causes necrosis of bone cells. So surgical guides, though they're neat and they can help guide surgery, there are some errors that can take place with them as well, and they do limit somewhat limit the amount of irrigation that's going to be going into the surgical area. This is something to consider. So at the beginning, I had mentioned taking good study models, and from those study models, you can create diagnostic wax-ups. Well, the other thing you can get from those diagnostic wax-ups are these little surgical guides, which basically gives you an idea of where the prosthetic's going to go. So in this photograph, you can see from the occlusal view, we basically want to have a screw retained position for this final prosthesis for this patient. So we put the surgical guide or the diagnostic wax up into place and basically do what we call a model surgery. And in the next slide here, you can see that we remove the guide, and as we've done the model surgery, you can see that there's a fairly significant buccal defect in terms of trying to achieve a screw retained position for this patient. So this would be a patient, if we were to try to get a screw retained position for their final prosthesis, we would require some significant buccal bone grafting prior to attempting any form of dental implant treatment. This is another photograph of another surgical guide with holes on the top to do a model surgery. So principles of cosmetic dentistry. So while we're treatment planning, why are we going to talk about cosmetic dentistry? I thought this was about implants and surgery and cool things like that. Why are we talking about cosmetic dentistry? So we're talking about cosmetic dentistry because, I mean, let's face it, the majority of patients are going to be coming in, they want to look good. So, I mean, many times patients are coming in and they'll just be happy to have increased retention, stability, and function of their prosthesis. However, why can't it look good? So I've put these slides in about principles of cosmetic dentistry in order to basically include them, as they will help us guide the choice of treatment to be rendered. And we will basically say that hard tissue is easier to sort of predict than the soft tissue reconstruction. And in terms of all of these principles that I'm going to discuss, they were taken from my colleague, Dr. Jordan Saul's STEP guide, which he had given us actually gave it to us back in dental school, but he had upgraded it in 2008. And I have basically included these as part of this presentation. I just wanted to provide a little bit of credit to my colleague for sharing this information with me. So the first thing you want to look at is the position of the upper lip to the central incisors in full smile. And basically you want to describe this as average, low, or high. So average and low are easy things to deal with. High becomes a bit of a challenge, because if it's the case that you'll be providing a patient with an implant solution and they don't have a lot of soft tissue, and they're going to be showing either long teeth or, worst case scenario, metal, that is not necessarily a good thing. The other thing that becomes a bit of a challenge is maintenance of the papilla for the patients. So as we will talk about later on, studies by Tarnow with respect to maintenance of papilla, we know that if their bone is at least a certain distance from the contact point, about 5 millimeters, you can maintain that papilla. However, many times the bone has receded beyond this point, and so maintenance of this papilla can be a challenge. And therefore, it's very important in the treatment planning appointment to discuss this with the patient so that there's no surprises from their perspective when the final prosthesis is delivered and there's this big black triangle and the patient's saying to you, I don't understand, I thought I wasn't going to have this. Smile evaluation. So in a normal sort of case, as we discussed about the smile for the upper lip position to the centrals and full smile, generally to consider it something normal, from the gingival crest, usually the inferior border of the upper lip sits either coronal or apical to these central incisors by at least 3 millimeters. Any more or any less than that is going to require some sort of treatment on our part. Maxillary arch form. So this is the maxillary arch form we all want. We want a convex maxillary arch form. Or second best would be something like a straight maxillary arch form, and the worst would be the person who we would describe as chronically being sad, even though they're not sad, but unfortunately they have this convex maxillary arch form, which convinces all of us that they're frowning when they actually are not. The number of teeth revealed at full smile is also very important, because it's going to ask you to communicate to the patient what we need to do from a treatment planning perspective. So if a patient has 6 teeth, great, we can work on 6 teeth. If it's 8 teeth, it's 8 teeth we recommend. If it's 10 teeth, it's 10 teeth we recommend. And if they have the Julia Roberts and they're showing from upper first molar to second first molar, then it's 12 teeth we need to address. The dentofacial analysis is also a very important thing to document. So have the patient smile and draw on the following: the silhouette of the maxillary incisal edge to the lower lip, the extent of lower teeth revealed, the extent of negative space, and finally the axial inclination of the maxillary anterior teeth. So from this perspective, is the interior intrapupillary line parallel with the horizon? Is the upper lip positioned within 3 millimeters of the gingival crest? Is the occlusal plane parallel with the intrapupillary plane? Does the smile line follow the outline of the lower lip? Is the commissural line parallel with the intrapupillary line and the occlusal line? And finally, are the negative spaces identical in size? Then we want to look at dental evaluation. Teeth in terms of height and width. Everyone talks about the golden proportions. Why do we talk about the golden proportions? Well, this is a proportion that is replicated, which has replicated itself within nature in numerous ways. This is just something which I guess we could say innately looks good to us. So from our perspective, from a treatment planning perspective, we want to make sure that we can try to provide our patients with a solution that's going to replicate these golden proportions for them. So that when we give them their final prosthesis, they say to us, wow, this looks awesome, as compared to wow, or yeah, it looks all right. Smile principles. So in terms of smile principles, we want to look at the smile line. If you have to bet the farm, dominance of the central incisors. Make those central incisors look good. You want to talk about silhouettes. We want to talk about the progression of maxillary incisal embrasures. We want to talk about progression of contacts, and we want to talk about axial alignment of the teeth. And finally, we want to talk about what they refer to as the gingival zenith, to make sure that that soft tissue basically embraces or caresses the teeth that we're providing for the patient. Treatment options. So In any sort of consent process, you have to discuss other treatment options for patients as well. So I had a patient in today who was seeking a single implant solution. And so treatment options that were discussed were the option of no treatment, which wasn't an option for the patient, as this patient has decreased masticatory efficiency from the loss of this tooth. Options like a removable partial denture, options like other fixed prostheses like Maryland bridge or a conventional bridge, and finally, discussion of something like a dental implant. And the main reason you want to discuss these other treatment options for the patient, other than consent law and all those sorts of things, is you want to provide a sound rationale for the selection of dental implant treatment over other options. And there must be a clear and demonstrable benefit to the patient. And there also has to be the reality of the proposed prosthesis. I once had a patient come in and ask me if I could give them 2 implants with an 8-unit bridge on 2 implants. And I said, that's something which violates Ante's law for normal teeth. Why would that be something which wouldn't violate Ante's law when it comes to an implant solution? You want to take a look at interarch relationships and occlusion. So generally when patients come in, I do 2 things. We do an extraoral and intraoral examination, as many other dentists do. But what are we looking at in these patients? So extraorally, we're looking at their facial type, their facial profile, taking a look at the midlines to see if they match up, taking a look at their nasolabial angles, and finally, the position of the lips, whether they're together at rest or they're apart. Intraorally, we take a look at angle classifications for both molars and cuspids. We classify the amount of overbite and overjet which they have, and we look for cross bites and how the teeth relate to themselves in the anterior, posterior, and transverse dimensions. So nomenclature for edentulous sites. So Dr. Edward Kennedy had sort of classified the edentulous sites for patients. So we have basically class 1, or I shouldn't say edentulous, sorry, it's partially edentulous. So there's class 1 is bilateral free-ended partially edentulous, class 2, which is unilateral free-ended partially edentulous, and class 3, which is unilateral bounded partially edentulous, and then class 4, which is bilateral bounded by a molar or another tooth anterior partially edentulous. Bone volume. So we talk about concepts of bone volume. So in terms of bone volume, division A bone has abundant height, width, length of bone, crown height to bone ratio is less than 1, and an angulation to force is within 30 degrees. Division B, moderate bone volume, barely sufficient. So there's adequate height, length, crown to height bone ratio is less than 1, and the angulation force is within 20 degrees. Division C, there's moderate bone volume, it's compromised in width, compromised in height, and has a crown to height bone ratio of greater than 1, compromised in angulation, and compromised in length. And finally, Division D, severe atrophy, which we call deficient, which is inadequate bone height, crown height to bone ratio of greater than 5, dehiscent mandibular canal, or pneumatized maxillary sinus and posterior regions of the mouth. And this comes from Dr. Carl Misch. Bone quantity in terms of height and width. So we have type A, good alveolar ridge form. Type B, moderate residual ridge form. Type C, advanced resorption, basal bone only. Type D, basal bone resorption. And type E, extreme resorption. Bone quality again. Type 1, almost the entire jaw is composed of homogeneous compact bone. Type 2, a thick layer of compact bone surrounds a core of dense trabecular bone. Type 3, a thin layer of cortical bone surrounds a core of dense trabecular bone and of favorable strength. And type 4, a thin layer of cortical bone surrounds a core of low dense trabecular bone. And this is from Dr. Lucombe and Dr. Zarb. So Misch qualified bone quality as D1, composed of almost all cortical bone, tactile sense of drilling into oak or maple wood on a scale of 1 to 10 is a 9 or 10 in bone strength, and is found primarily in the mandibular anterior. Misch then described type D2 bone, which is comprised of thick crestal layer of cortical bone and coarse trabecular bone, Tactile sense of drilling into white pine or spruce wood. I'm assuming Dr. Mish was a carpenter. On a scale of 1 to 10 is a 7 or 8 in bone strength, and it's found in all regions of the mandible and the anterior maxilla. Type D3 bone, it's comprised of thin cortical bone on the crest and fine trabecular bone. Its a tactile sense of drilling into balsa wood on a scale of 1 to 10 is a 3 or 4 in bone strength, 50% weaker than D2 bone, and it's found primarily in the posterior mandible or the maxilla. And finally, type D4 bone, which we don't like working in, it's comprised of almost all fine trabecular bone, and it's the tactile sense of drilling into styrofoam. On a scale of 1 to 10, it's a 1 or 2 in bone strength, and it's found primarily in the posterior maxilla. So this photograph here basically shows you a visual of what type D1, D2, D3, D4 bone look like and where they can be found in respective areas of the mouth. Bone quality again. So D1 from a radiographic perspective would be described as greater than 1250 Hounsfield units. D2 would be described as 850 to 1250 Hounsfield units. D3 as being from 350 to 850 Hounsfield units. And D4 as being 150 to 350 Hounsfield units, and D5, which we didn't even discuss, as being less than 150 Hounsfield units. This is also from Dr. Carl Mish. Ridge descriptions. So class 1, dentate. Class 2, immediately post-extraction. Class 3, well-rounded ridge form, adequate in height and width. Class 4, knife edge ridge form, adequate in height and inadequate in width. Class 5, flat ridge form, inadequate in height and inadequate in width. And Class 6, depressed ridge form with some basal loss evident. And once again, type A, C, B, C, and D, and E from Leucom and Zarb, type A ridge descriptions, most of the alveolar ridge is present. B, moderate residual ridge resorption has occurred. C, advanced residual ridge resorption has occurred and only basal bone remains. D, some resorption of the basal bone has started. E, extreme resorption of the basal bone has taken place. So how do we define extraction sockets? So in terms of extraction sockets, you have a class 1 defect, which is a defect completely within the bony housing and all the walls are intact. Thus, the diameter of the site to be regenerated is greater than the diameter of the implant. In a class 2 defect, the defect is 3 or 4 walls are intact, with the fourth wall of having either a dehiscence or a fenestration. And this type of defect still may be self-containing for natural space making. A class 3 defect is a type 1. There's two types. There's a type 1 and a type 2. Type 1 has a defect that has an adequate ridge height but inadequate ridge width, for example, the knife edge ridge. Type 2 is a defect wherein 2 of the 4 walls are intact and the other 2 either present with dehiscence or fenestration. Finally, we have a class 4 defect, is a defect in which inadequate vertical height is present. This is from Dr. Meltzer. So for a type 1 socket in this description here is that the facial soft tissue and buccal plate of bone are at normal levels in relation to the cemento-enamel junction of the pre-extracted tooth and remain intact post-extraction. In a type 2 socket, the facial soft tissue is present, but the buccal plate is partially missing following extraction of a tooth. And finally, in a type 3 socket, the facial soft tissue and the buccal plate of bone are both markedly reduced after extraction. In terms of papilla, why are we talking about papilla? Papilla are very important. They're important because they're very difficult to create if it's the case that you are placing an implant in a patient who has lost bone. So what we know for papilla, if we go back to studies by Tarnow, is that the vertical distance from the crest of the bone to the contact point between the two teeth, when this distance was 5 millimeters or less, the papilla almost always completely filled the interdental space 100% of the time. When the distance was 6 millimeters, the interdental space was filled about 55% of the time, and at 7 millimeters, the interdental space was completely filled about 25% of the time. The vertical distance on the tooth side from the crest of the bone to the height of the papilla between a tooth and an implant, when the papilla completely filled the interproximal space, the distance was on average 4.5 millimeters. the interdental papilla was present when this distance was 4 millimeters or less. The horizontal distance from the implant to the adjacent tooth. A strong correlation was found between bone loss at adjacent teeth and the horizontal distance implant to tooth. Bone loss at tooth surface was most severe for a horizontal distance of less than 2 millimeters. The horizontal distance between two adjacent implants. The distance should be more than 3 millimeters in order to minimize the vertical loss of the inner implant bone crest. The lateral distance from the implant to the crest of the ridge was 1.34 millimeters and 1.4 millimeters. The vertical distance from the crest of bone to the height of the interproximal papilla between adjacent implants. Only 2, 3, or 4 millimeters of soft tissue height can be expected to form over the inner implant crest of bone. So what's the take-home point here? The take-home point is, remember that if you're trying to maintain a papilla for a patient, make sure that there's adequate bone that's going to be apical to the proposed contact point that you're proposing. And the number that you want to look for is at least 5 millimeters. If it's not 5 millimeters, you need to tell the patient that there's a good chance that this papilla is not going to regenerate. So normal interdental papilla fill the embrasure space to the apical extent of the interdental contact point. You have a class 1. The tip of the interdental papilla lies between the interdental contact point and the most coronal extent of the intraproximal cemental enamel junction. Class 2, the tip of the interdental papilla lies at or apical to the interproximal CEJ, but coronal to the apical extent of the facial CEJ. And finally, Class 3, the tip of the interdental papilla lies with or apical to the facial CEJ. Concepts of biological width. We discussed this in Lecture 1. We're referring back to Dr. Gargiulo's studies from the 1960s. The concept of biological width does play in the world of dental implants as well. Just as is significant for natural teeth, you don't want to impinge upon a patient's biological width. You don't want to impinge upon a patient's biological width with dental implants as well. And the distance to look for here is 3 millimeters. So a quick exam. So a patient comes to your office. They ask you very quickly, Doc, am I a candidate for a dental implant? So we talked about study models, photographs, interarch relationships, periodontal exams, all types of other things. What's a quick exam to tell a patient if they're just a cursory exam to determine whether a patient's going to be a candidate for a dental implant or not? So what I usually do is you want to look for at least 10 millimeters of interarch clearance between the opposing arches, because that's the amount of space you're going to need for your tooth, for your abutment, and for your implant. You want to make sure that there's adequate root form, that you're going to be, from a radiographic perspective, you're going to be at least 2 millimeters away from the roots if you're going to be placing a dental implant. You want to make sure that there's at least 6 millimeters of bone width. So it's going to help maintain at least 1.5 millimeters of cortical bone on the buccal and lingual aspects of this implant, assuming that you're using a 3 millimeter diameter implant. You want to make sure that there's adequate attached tissue. From a long-term perspective, attached tissue provides that much better a junctional epithelium for dental implants than mucosa, which can end up causing issues for patients in terms of peri-implant diseases. And finally, you want to be at least 2 millimeters away from vital anatomy for the patient and 3 millimeters anterior to the mental foramen. So patient selection. So we've talked about all the data that we can collect and discussing things with patients in terms of their expectations of what we can do for them. So how do we select our patients? Pretty much everyone who practices dentistry has a list of patients who they probably wish they had not worked on. And the same thing can occur in dental implant therapy. Unfortunately, patients come into our doors seeking dental implant solutions for missing teeth. They come to us with a myriad of complaints about their previous prostheses or previous interventions that have taken place. What are the factors that are related to patients that are going to relate to success or relate to failure? This comes from a literature review by Porter in general dentistry. So basically factors that are related to success for patients is the quantity of bone, the quality of the bone, the patient's age. Obviously, younger people do better than older people. The dentist's experience. There's a study that was done that basically said that if you've placed at least 50 implants, that you've gained significantly more experience than someone that has not. The location of the implant, so whether it's in the posterior mandible, so it's a matter of surgical access, or if it's in the anterior maxilla, which is going to be a highly aesthetic area. the length of the implant that's being proposed, axial loading of the implant as opposed to subjecting the implant to non-working forces and lateral forces or parafunctional forces, and then finally good oral hygiene on the part of the patient. So the patient needs to understand that implants don't last forever. The principle of dynamic reciprocity, which we had discussed in lecture 1, is very important. So if the patient's going to have horrific plaque and buildup of calculus around their implant, and is going to end up developing peri-implant mucositis or things like peri-implant disease, this is not going to be a good thing for from a success perspective. So what are the factors that we can say are related to failure? So in terms of failure, poor bone quality is an obvious one. Chronic periodontitis is also another issue which is related to failure. We're learning more and more that the majority of the organisms that are involved in periodontal disease are also the ones that are involved in peri-implant diseases. Systemic diseases are also things like uncontrolled diabetes, people who are immunosuppressed or have immunodeficiency, patients who are smoking, patients who have unresolved caries and infection, advanced age, implant location based on the type of bone that may be in that location, short implants, eccentric loading, inadequate number of implants that were placed, parafunctional habits, and finally, loss of integration with the hard and soft tissues. So we then talk about perception of the case. So in a straightforward case, you can easily visualize the end result and the treatment stages are predictable. And in a complex case, the end result cannot be easily visualized without extensive case workup, and multiple treatment stages are required to achieve the desired outcome, and complications are to be expected. In terms of patient selection for tooth position, a straightforward case, the teeth to be replaced conform to the existing arch form, and the existing teeth easily determine the optimal prosthetic tooth position. In a complex case, there are no adjacent teeth, or those present are in an unsuitable position, and extensive case workup is required to determine the optimal prosthetic tooth position for aesthetics and function. Patient selection with respect to implant surgery. So in a straightforward case, the dental implant surgery is without anatomically related risks and can be carried out without the need for significant hard tissue grafting, including onlay bone grafting and sinus grafting. The surgical care can be provided by an appropriately trained dentist. In a complex case, the dental implant surgery is more difficult, with anatomically related risks, and may require significant hard tissue grafting, including onlay bone grafting and sinus grafting. The surgical care should be only provided by an oral maxillofacial surgeon, periodontist, or a dentist with advanced surgical training and extensive experience. Finally, patient selection with terms of soft tissue. In a straightforward case, there is little or no need to augment or alter the position of the peri-implant mucosa, and such intervention will not require significant grafting of hard and soft tissue. In a complicated case, there is a need to augment or alter the position of the peri-implant mucosa, requiring significant grafting of hard and soft tissue. With respect to patient selection in terms of occlusion, in a straightforward case, the teeth can be replaced by conforming to the existing occlusal scheme at the same vertical dimension. In a complicated case, there is a need to substantially change the existing occlusal scheme and/or vertical dimension for the patient. The prosthetic care should be provided by a prosthodontist or a general dentist with advanced prosthodontic training and extensive experience. We then talk about patient selection with respect to aesthetics. In a straightforward case, the aesthetic requirements of the case are not high, and the expectations of the patient are reasonable. This is once again why we discussed principles of cosmetic dentistry in this presentation. In a complicated case, the aesthetic requirements of the case are high, as are the expectations of the patient. So we'll move on to our next lecture, which is lecture 3, which is all about bone metabolism and wound healing. I have once again included a list of the references that we have used in this presentation. On behalf of all the folks at Cataraqui Dental Implant Institute, I want to thank you for listening to our lecture.